Imagine a medication that could potentially tackle everything from, stubborn high blood pressure and difficulty with urination,
Mm.
even things like debilitating PTSD nightmares or helping pass kidney stones. How can one type of drug really reach into such different parts of the body and have such, well, varied
It
effects?
does sound almost contradictory, doesn't it?
Okay.
But it really speaks volumes about the incredible precision and sometimes the surprising ripple effects of targeting specific points in our body's complex chemical communication network.
Yeah.
The sources you brought us today, they offer a fantastic map, really, to understand exactly how some key players, alpha blockers and nitrates, achieve these widespread effects.
Absolutely. So our mission with this deep dive is to really unpack the fascinating world of alpha blockers and separately but relatedly, anti-anginal drugs, specifically nitrates.
Right.
We're going to use your provided articles and research to go beyond just, listing facts. We want to get into how these molecules actually interact with your body's signaling systems, explore their diverse uses, the critical considerations, and maybe uncover some surprising connections along the way.
Yeah, definitely.
I'm genuinely excited to see how hitting just one specific molecular target can have such big downstream effects.
And the materials, they lay it out beautifully. We can trace the core mechanisms, look at the approved uses, even some explored off-label uses.
Mm-hmm.
And most importantly, I think, for anyone dealing with these medications is understanding the vital side effects and potential drug interactions that come with such powerful agents.
Okay, so let's unpack this. The fundamental concept behind alpha blockers, based on these sources anyway, it boils down to interfering with the body's chemical messengers by targeting something called alpha receptors. Can you walk us through what that actually means in practice?
Sure. Think of your nervous system like a huge communication network, right?
Yeah.
It sends messages using chemical signals, neurotransmitters,
Mm-hmm.
things like adrenaline and norepinephrine.
Okay.
These chemicals act like keys. They're sent out looking for specific locks on the surface of your cells. And these locks, they're the receptors.
Right.
So when the right key fits into the lock and turns it sends a signal inside the cell telling it to do something like contract a muscle or increase its activity.
So alpha blockers are what? Keys that don't quite work.
Precisely. That's a great way to put it. Alpha blockers are molecules designed to fit into those alpha receptor locks, but they can't turn the lock. They just kind of sit there.
Ah, okay.
And this is the crucial part. By sitting in the lock, they block the body's own neurotransmitter keys, adrenaline and norepinephrine, from getting in and delivering their usual turn the lock message. So the cell doesn't get activated in the same way.
They're essentially blocking the natural signal pathway. Now, the sources make it clear it's not just one kind of alpha receptor, right? There are subtypes, and that seems really important for understanding their different effects.
Oh, it's absolutely critical. There are two main types we talk about. Alpha-1, often written as alpha-1, and alpha-2 or alpha-2. And importantly, they're distributed differently throughout the body. That's why blocking them can have such distinct outcomes.
Okay, so where do these different locks, these receptors, tend to be found?
Alpha-1 receptors. They're particularly common in the smooth muscle lining your blood vessels. When adrenaline or norepinephrine hits them, those vessels constrict, which increases blood pressure.
Right, the tightening effects.
Exactly. But they're also heavily present in the smooth muscle of the prostate and the base of the bladder that influences urinary flow. You'll also find them in the muscles that control your pupil size, in your skin, causing goosebumps, and even to some degree in the heart itself.
Okay. And alpha-2?
Alpha-2 receptors are a bit different. They're more involved in regulating neurotransmitter release in the nervous system itself. Often, they're actually located on the nerve endings that release norepinephrine, acting kind of like a feedback brake to slow down further release.
Interesting. Like a self-regulating mechanism?
Sort of, yeah. You also find alpha-2 receptors on platelets involved in clotting, in the pancreas influencing insulin release, in fat cells, and in some blood vessel muscle too, though their role in vessel constriction is generally less prominent than alpha-1.
So blocking alpha-1 mainly leads to relaxation, where it usually causes constriction like in blood vessels or the prostate, and blocking alpha-2 might affect signaling feedback loops or other processes. That distribution, it explains a lot about their uses. How are these alpha blockers classified then, based on which receptors they target?
That classification is really key to predicting their main effects and side effects. You have the non-selective blockers, like phenoxybenzamine and phentolamine. These block both alpha-1 and alpha-2 receptors.
Okay, broad spectrum.
Then, probably the most commonly used group in medicine today are the selective alpha-1 blockers. These are drugs like prazosin, doxazosin, terazosin, alfazosin, tamsulosin, and silodosin. They primarily target just the alpha-1 receptors.
Got it.
The sources do mention there aren't currently any widely approved selective alpha-2 blockers for medical use, though some compounds like yohimbine, which has selective alpha-2 activity, are being explored or used in other contexts.
Right.
And as you noted earlier, some medications like carvedilol and labetalol are interesting because they combine both alpha and beta blocking properties in one molecule.
Okay, with that mechanism and the classifications laid out, the diverse medical uses start to make a lot more sense. Let's jump into those. High blood pressure, or hypertension, is a big one.
Exactly. Many forms of high blood pressure involve that excessive constriction of blood vessels, increasing resistance to blood flow. So selective alpha-1 blockers like prazosin, doxazosin, terazosin, they work by blocking the alpha-1 receptors in those blood vessel walls. This allows the smooth muscle to relax, which reduces that vascular resistance and consequently lowers blood pressure.
But the sources seem to suggest they aren't always the very first choice for treating standard hypertension compared to, say, ACE inhibitors or maybe beta blockers. Why is that?
That's a great question, and it's an important nuance the sources highlight. While they definitely lower blood pressure effectively, large clinical studies haven't consistently shown the same long-term benefits in preventing major events like heart attacks or strokes compared to some other drug classes, at least when used as the initial therapy for typical hypertension.
Ah.
Okay, however, they are absolutely still part of the treatment toolbox. They're often used perhaps in combination with other medications or especially when a combined alpha-beta blocker like labetalol or carvedilol is appropriate, particularly if the patient has other conditions that might also benefit from alpha blockade.
That leads perfectly into another major use. Benign prostatic hypoplasia, BPH. For anyone experiencing that, feeling of not being able to fully empty their bladder or struggling to start urinating, this is directly relevant. We even have that helpful image in the sources showing the enlarged prostate sort of squeezing the urethra.
Yeah, this is a classic example of targeted smooth muscle relaxation.
Yeah.
PPH is very common, especially in older men, and it involves the prostate gland getting larger. This growth can physically squeeze the urethra that runs through it, obstructing urine flow.
Right.
But it's not just the physical size. The tension in the smooth muscle within the prostate itself and at the base of the bladder plays a really significant role. Alpha-1 blockers, particularly drugs like alfazosin, tamsulosin, terazosin, doxazosin, prazosin, and silodosin, they relax that specific smooth muscle.
Ah, okay.
That relaxation at the bladder neck and within the prostate makes it easier for urine to flow out, relieving those, bothersome urinary symptoms.
So it's less about actually shrinking the prostate itself and more about just easing that squeeze, relaxing the muscle.
Precisely. And there's a neat clinical overlap here that the sources point out. If a patient happens to have both BPH and hypertension,
right,
a single medication like prazosin, doxazosin, or terazosin could potentially help treat both conditions simultaneously.
That's sufficient.
It can be.
Yeah.
On the flip side, a drug like tamsulosin is often favored if the patient only has BPH symptoms and doesn't really need significant blood pressure lowering. It tends to have less effect on overall systemic blood pressure compared to some of the other alpha-1 blockers.
It's fascinating how targeting the exact same receptor type can help two seemingly very different issues, just because that receptor happens to be located in both blood vessels and the prostate area.
It really highlights how interconnected the body's systems are, doesn't it?
Yeah, definitely. Moving to a less common but critically important use mentioned in the sources, pheochromocytoma and paragangliomas. These sound pretty intense.
They are. These are rare tumors, thankfully, but they can release excessive amounts of adrenaline and norepinephrine right into the bloodstream. This massive hormone surge can cause dangerously high blood pressure spikes, palpitations, sweating, really severe symptoms.
Wow.
In this situation, the non-selective alpha blockers, specifically phenoxybenzamine and phentolamine, are absolutely essential. By blocking both alpha-1 and alpha-2 receptors, they counteract the widespread constricting effects of those excess hormones, helping to control the vascular resistance and blood pressure before surgery can be done to remove the tumor. They're crucial for stabilizing the patient.
Yeah, now let's get into some of the truly surprising uses mentioned in the sources, the off-label applications, the ones you might not immediately expect from a drug primarily known for blood pressure or BPH. This is where it gets really interesting for me.
Me too. The exploration of high-dose prazosin for PTSD nightmares is a standout example. The theory, based on the sources, is that by blocking alpha-1 receptors, possibly in the brain,
In the brain, okay.
it might dampen the effects of norepinephrine. That's a neurotransmitter heavily involved in the fight or flight response and the hyperarousal state that seems to contribute to those vivid, distressing nightmares in PTSD. So it's not just relaxing muscles in the body. It's potentially modulating brain circuitry related to trauma response.
That's incredible.
It is, though the sources do caution about side effects at these higher doses needed for PTSD, like significant dizziness, that notable first dose effect we need to talk more about, weakness, maybe nausea, fatigue.
So it's acting on alpha receptors in the brain then, not just out in the body's periphery like for blood pressure.
Exactly. It seems alpha-1 receptors do play roles within the central nervous system too, and targeting them there appears to have potential effects on things like sleep architecture and anxiety related specifically to PTSD.
Wow. Okay, what about Raynaud's disease, where circulation in fingers and toes gets severely affected by cold or stress?
That's another area where alpha blockers have been explored. Since Raynaud's involves exaggerated blood vessel constriction in the extremities, blocking that seems logical.
Makes sense.
The sources mention alpha-1 blockers like prazosin have been tried. But interestingly, they highlight that some studies suggest alpha-2 blockers, specifically yohimbine, might actually show more promising results in reducing Raynaud's symptoms, potentially with fewer systemic side effects compared to the alpha-1 blockers for this specific condition. It's still an area of investigation.
And even erectile dysfunction, that feels like another big leap.
It does, yeah.
Yeah.
And the sources mention testing yohimbine again, that alpha-2 blocker, and also the non-selective blockers, phentolamine and phenoxybenzamine for ED. The proposed mechanism, again, relates to blood flow trying to reduce the vasoconstriction that can impede the blood flow necessary to achieve and maintain an erection.
Right.
However, they're very quick to list significant potential side effects associated with these uses, things like palpitations, tremor, even elevated blood pressure and anxiety with yohimbine, and headache, flushing, nasal congestion with phentolamine. It's definitely not a first-line approach for ED today, given the other highly effective options available, but it shows the broad reach of trying to modulate alpha receptors for vascular effect.
Okay, but kidney stones. Using alpha-1 blockers like tamsulosin to help pass a kidney stone, that seems totally disconnected from blood vessels or the prostate gland.
It feels that way initially, doesn't it?
Yeah.
But it circles right back to relaxing smooth muscle. The ureters, those are the tubes that carry urine from your kidneys down to your bladder. They also have smooth muscle walls.
Ah, okay.
When a kidney stone gets stuck in a ureter, these muscles can spasm around it, causing intense pain and making it harder for the stone to move down. So the off-label use of alpha-1 blockers like tamsulosin, alfuzosin, doxazosin, terazosin, silodosin is based on the idea that they can help relax that smooth muscle in the ureter walls.
Making it easier for the stone to pass.
Potentially, yeah. By relaxing the ureter, it might widen the passage slightly and reduce the painful spasm, possibly making it easier for the stone to move down and pass out naturally. It's using the same fundamental muscle relaxing effect we saw in BPH, just applied to a different set of, well, pipes.
That connected is fascinating. The same basic mechanism, smooth muscle relaxation via alpha-1 blockade, applied in very different locations for very different problems. And just circling back quickly, the combined alpha-beta blockers, their use in congestive heart failure is mentioned too.
Yes, absolutely.
Yeah.
Drugs like carvedilol, which hit both alpha and beta receptors, are really mainstays in managing chronic heart failure. They help reduce the heart's workload in multiple ways by lowering blood pressure through alpha blockade and by decreasing heart rate and the force of contraction through beta blockade. This combination helps improve the heart's efficiency over time in patients with weakened heart muscle.
Wow, that is a seriously wide range of applications, all stemming from blocking these alpha receptors in different ways or different places. But with such potent effects, must come important considerations and potential side effects. What do the sources really emphasize here?
This is where vigilance is absolutely key. The sources really underscore that side effects can vary quite a bit depending on the specific alpha blocker you're using, whether it's selective, non-selective combined alpha-beta.
Right.
But there are some common themes and particularly important warnings that apply across the board, or to specific types.
And one of the most well-known, maybe notorious, is the first dose effect, particularly with some of the selective alpha-1 blockers. Can you explain that phenomena?
Yes, this is something patients really need to be aware of, and it gets highlighted strongly. With drugs like prazosin, doxosin, and terazosin especially, the very first dose can cause a sudden, sometimes quite dramatic, drop in blood pressure.
Why does that happen?
It's because your body hasn't had time to adjust yet to the widespread blockade of alpha-1 receptors, particularly the ones constricting your blood vessels. So when those relax all at once, pressure can fall quickly. This often leads to orthostatic hypotension, that feeling of dizziness, lightheadedness, or even feeling like you might faint when you stand up suddenly.
Okay, that sounds unpleasant, potentially dangerous.
It can be. In some cases, it can lead to actual fainting or syncope. That's why the sources strongly emphasize taking the first dose, and sometimes the first few doses, right at bedtime. The idea is to minimize the risk of symptoms or falls while you're likely to be lying down.
Makes sense.
But it also brings an increased risk of falls, particularly in older adults who might get up during the night to use the bathroom, for example. They need to be especially cautious.
That sudden drop sounds like something you definitely need to be prepared for and manage carefully. What about side effects related more to the genitourinary system, given their common use for BPH?
Yeah, it's interesting. While the primary goal in BPH is to improve urine flow, paradoxically, sometimes these drugs can cause fluid retention or edema swelling, usually in the ankles or feet. And the sources highlight two very rare but potentially very serious side effects, primarily in men. One is priapism. This is a persistent, painful erection that lasts for hours and won't go away on its own. It's considered a medical emergency because if it's not treated promptly, it can lead to permanent damage and impotence.
That sounds incredibly serious.
It absolutely is. Immediate medical attention is required. The other rare effect mentioned is anejaculation, which is the inability to ejaculate during orgasm, although orgasm itself might still occur. It's a stark reminder that relaxing the muscles involved in urinary function can sometimes have unintended consequences on related sexual functions, too.
Right. Looking back at that BPH image, you can sort of visualize how relaxing muscles in that area could affect different functions. But the seriousness of something like priapism really needs emphasis.
Absolutely. Needs immediate attention.
What are some of the more common, perhaps less severe side effects people might experience?
Dizziness or lightheadedness, even beyond the first dose effect, is quite common. Drowsiness, a feeling of weakness or fatigue, headache, and nasal congestion like a stuffy nose are also frequently mentioned in the sources.
Okay.
Some people might also experience a pounding heartbeat or palpitations, maybe some sleep disturbances, or dry mouth. With the non-selective blockers specifically, because they also block that alpha-2 brake on norepinephrine release.
Right, the feedback loop.
You can sometimes get a reflex increase in heart rate called tachycardia, or even muscle tremors. This happens because more norepinephrine might be floating around, available to stimulate other receptors, like beta receptors in the heart or muscles.
Are there certain conditions or situations where these alpha blockers should generally be avoided or used with extreme caution?
Yes, the sources list several important contraindications or cautions. They should definitely be used cautiously, or perhaps avoided, in individuals who already have a history of low blood pressure, hypotension, or significant postural symptoms. Also, in certain types of severe heart failure where further lowering of blood pressure could be problematic.
Okay.
If someone already has issues with urinary incontinence, using a drug that relaxes the bladder neck further needs careful consideration. Similarly, with fluid retention, sometimes a diuretic might be needed alongside the alpha blocker to manage swelling.
Any other specific warnings?
Yes, there's a specific risk noted during cataract surgery called intraoperative sloppy iris syndrome, or IFA, which surgeons need to be aware of if a patient is taking an alpha-1 blocker, especially tamsulosin. Also, the non-selective blockers are generally cautioned against during breastfeeding, and potentially in patients with certain severe kidney, circulatory, or respiratory infections, particularly the non-selective agents.
And interactions with other medications seem like a really major point of caution across the sources.
Absolutely critical. This is definitely not something to take lightly, and the sources provide very strong warnings here. Combining alpha blockers with other medications that also lower blood pressure, like other hypertension drugs, diuretics, even some antidepressants, can lead to an unsafe additive drop in blood pressure.
Okay, that makes sense.
And the interaction with erectile dysfunction medications like sildenafil, Viagra, tadalafil Cialis, and others is particularly dangerous. It's strongly emphasized. Both classes cause vasodilation, but through different mechanisms. Combining them can cause a severe, potentially life-threatening drop in blood pressure. It's a huge no-no, generally.
That is crucial information.
Definitely. They can also interact with other things, certain anxiolytics, some antihistamines, even stimulants. Depending on the specific alpha blocker and the other drug, these interactions could potentially cause dangerous hypotension or, in some cases, irregular heart rhythms. For example, that alpha-2 compound yohimbine can be tricky. It might raise blood pressure if combined with stimulants, or dangerously lower it with other BP meds. And mixing combination alpha-beta blockers with other alpha or beta blockers needs careful management to avoid excessive effects.
So the takeaway is,
The absolute vital takeaway is that any patient taking an alpha blocker must tell their doctor and pharmacist every single other medication, over-the-counter drug, supplement, or herbal remedy they're taking. Full stop.
Got it. Given all that, how long are these medications typically taken for? And is it ever safe to just stop taking them?
Well, for chronic conditions like BPH or ongoing hypertension management, the selective alpha-1 blockers are often taken long-term, potentially for many years. The non-selective ones, like those used for pheochromocytoma before surgery, might be used for shorter periods.
And stopping.
The sources are crystal clear and emphatic on this. You must never stop taking these medications suddenly on your own without talking to your doctor first. Abruptly stopping, especially the non-selective blockers or even the selective ones if you're on a significant dose, can lead to a dangerous rebound effect, like a sudden spike in blood pressure or a severe worsening of BPH symptoms.
So how can someone stop, if needed?
Stopping might be possible, of course. Perhaps the underlying condition significantly improves through other lifestyle changes or treatments, or maybe surgery addresses the issue, like prostate removal for BPH, or maybe the doctor decides to switch to a different class of medication. But any stopping or changing of dose must be done gradually and under strict medical supervision to manage potential withdrawal or rebound effects safely.
Okay. And finally, when should someone on these medications know it's definitely time to call the doctor or seek immediate medical attention?
You should always feel comfortable contacting your doctor if you have any new concerns, worsening symptoms, or bothersome side effects. But you should seek immediate emergency medical help for any really serious issues. Things like fainting or feeling like you're about to faint, new or worsening chest pain, severe or irregular palpitations, that prolonged and painful erection we discussed, priapism, or any signs of a severe allergic reaction, like difficulty breathing, hives or swelling of the face, lips, tongue, or throat.
That's an incredibly thorough look at alpha blockers. We've gone from their microscopic lock-and-key action all the way to their surprisingly varied applications. Blood pressure, BPH, even those off-label uses like PTSD nightmares or kidney stones, and covered the absolutely essential safety considerations like that first dose effect and priapism. It really underscores the power and the complexity involved.
It really does. It shows how targeting one specific type of receptor can lead to such widespread physiological changes throughout the body.
Okay, now let's transition. Let's shift gears to another class of drugs mentioned in the sources. They also affect blood vessels and smooth muscle, but their primary focus is on a different kind of chest pain. We're talking about anti-anginal drugs and specifically nitrates.
Right. So while alpha blockers are primarily acting on those alpha-adrenergic receptors, nitrates work through a completely different pathway to cause vasodilation. And their main stage, their primary area of action for this purpose, is the cardiovascular system, specifically for addressing angina.
So before we dive into the drugs themselves, maybe just quickly clarify what exactly is angina?
Sure. Angina, or angina pectoris, is the medical term for chest pain, pressure, or discomfort that happens when the heart muscle itself isn't getting enough oxygen-rich blood.
Okay.
The sources explain the core issue really clearly as a mismatch. The heart muscle's demand for oxygen exceeds the supply it's receiving through its own blood vessels, the coronary arteries.
And what usually causes that critical supply-demand imbalance? Why isn't the heart getting enough oxygen?
The most common culprit, by far, and shown really well in that image in the sources, is atherosclerosis. That's the buildup of fatty plaques inside the coronary arteries. This plaque narrows the arteries, physically restricting blood flow, especially when the heart needs more oxygen, like during exercise or stress.
Okay, so blocked pipes, basically.
Pretty much. Another potential cause, though less common, is vasospasm, where the muscles in the coronary artery walls suddenly tighten or spasm, temporarily clamping down and reducing blood flow. Either way, narrowed artery or spasming artery, the heart muscle gets starved for oxygen, and it signals this distress as pain or pressure, which we call angina.
So anti-anginal drugs like nitrates are aiming to fix that mismatch somehow.
Precisely. The overall goal is to restore that balance between oxygen supply and demand. They try to do this in one of two main ways. either by increasing the amount of oxygen delivered to the heart muscle, usually by improving blood flow to the coronary arteries, or, and this is particularly significant for nitrates, by decreasing the heart's workload so it simply doesn't need as much oxygen in the first place.
Okay, and how do nitrates accomplish this reduction in workload based on the sources? What's their main trick?
What's really fascinating here is their primary mechanism of action. Nitrates get converted in the body into nitric oxide, or NO. Nitric oxide is a really potent natural signaling molecule that causes smooth muscle relaxation, particularly in blood vessel walls.
Okay, so they relax blood vessels, like alpha blockers, but different mechanism.
Exactly, different pathway. And while nitrates do relax both arteries and veins, their most significant effect, especially at the typical doses used for angina, is actually on the veins. This widespread relaxation of the veins is called venodilation.
Venodilation. Okay, so relaxing the veins, how does that help the heart?
When the veins relax and widen, more blood tends to pool in the venous system, sort of further away from the heart. This means less blood actually returns to the heart chambers with each beat. This reduction in the volume of blood coming back to the heart is known as reducing preload.
Ah, preload. So by reducing the amount of blood coming back to the heart doesn't have to pump as forcefully or stretch as much with each beat.
Exactly right. Less preload means the heart muscle wall isn't stretched as much before it contracts. It doesn't have to work as hard to eject the blood, so its energy requirement, its oxygen demand, goes down. This is a primary way nitrates effectively relieve angina symptoms by easing the heart's workload.
So it's mainly about reducing demand. Do they also help supply?
They do have some effect there too, yes. Nitrates also cause some dilation of the coronary arteries themselves, the ones supplying the heart muscle. This can help improve blood flow and oxygen supply directly, especially if there's some spasm involved or if collateral vessels can open up. But generally, that reduction in preload through venodilation is considered their most impactful mechanism for relieving exertional angina.
Okay. Now, the sources describe different types of nitrates and different ways they're used. Can you break that down?
Yes, and the form of the nitrate is absolutely critical to understanding how and when it's used. We have the short-acting nitrates, most famously nitroglycerin, often abbreviated as GTN. These are used for the immediate relief of an acute angina attack that's happening right now.
The emergency use ones.
Exactly. They typically come as tiny sublingual tablets. You place them under your tongue or as a spray, also used under the tongue or onto the cheek lining. This sublingual route is key because it allows the drug to be absorbed directly into the bloodstream, bypassing the liver's first-pass metabolism, where it would otherwise be broken down quickly.
So it works fast.
Very fast, usually within a minute or two, to provide rapid relief. The sources also describe using these short-acting forms preventatively taking a dose right before engaging in an activity that you know is likely to trigger your angina, like climbing stairs or walking in cold weather.
And the instructions for actually taking that sublingual nitroglycerin during an attack seem very specific in the patient guide material.
They are, and it's absolutely vital information for patients. The standard advice is, when chest pain starts, sit down immediately. Take one dose that might be one tablet under the tongue or one or two sprays as directed for your specific product. Wait 5 minutes. If the chest pain is not relieved after those 5 minutes, take a second dose. Wait another 5 minutes. If you're still in pain, a third and final dose can usually be taken.
Okay, up to 3 doses in 15 minutes.
Right, but here's the absolutely critical point emphasized in the sources. If the chest pain is not significantly better or gone after that first dose, or if it seems to be getting worse at any point, you should call for emergency medical help immediately, like calling 911 or your local emergency number.
Don't just keep taking more if the first one doesn't work well.
Exactly. You shouldn't wait through all 3 doses if the first one provides little or no relief. It could be a sign that something more serious is happening, like a heart attack, which requires urgent hospital treatment. Nitroglycerin treats angina pain, but it doesn't stop a heart attack that's in progress.
That's a crucial distinction. So the short-acting forms are for acute relief or immediate prevention. What about the longer-acting nitrates mentioned?
These are used differently. They're intended for the long-term prevention of angina episodes, taken on a regular schedule, to try and reduce the frequency and severity of attacks overall. Examples include drugs like isosorbide dinitrate and isosorbide mononitrate. These often come in standard tablet forms or, more commonly now, in extended-release formulations, like one well-known brand name, Imdur, designed to provide effects over many hours.
So they're for maintenance, not rescue.
Precisely. The sources are very clear that only the rapid onset forms the sublingual tablets, the spray, or sometimes intravenous IV nitroglycerin given in a hospital setting are appropriate for treating an acute angina attack that's happening right now. The longer-acting tablets are too slow to work for immediate relief.
Okay, let's talk about the common side effects people might experience when taking nitrates. What can patients typically expect?
A very, very common side effect, almost a sign that the drug is working because it relates directly to the vasodilation, is a throbbing headache.
Ah, the vasodilation in the head.
Exactly. Expanding blood vessels in the head causes that sensation. It often diminishes over time as the body adjusts, but it can be quite bothersome initially. Other common side effects include a flushed feeling in the face, dizziness or lightheadedness, again due to the blood pressure lowering effect.
Right, the orthostatic effect again.
Yes, similar idea. Also, palpitations, maybe a feeling of slight nausea. And specifically with the sublingual spray, some people report a burning or tingling sensation under the tongue where it's sprayed.
And then there's that major drug interaction that is highlighted as extremely dangerous in the sources. You mentioned it briefly with alpha blockers, too.
Yes, and it bears repeating because it's absolutely critical, potentially life-threatening. The sources issue the strongest possible warning. Nitrates should never be taken concurrently with medications used for erectile dysfunction. This includes sildenafil, Viagra, tadalafil, Cialis, Vardafil, Levitra, and Avanfil, Stendra.
Why is that combination so dangerous?
Because both drug classes, nitrates, and these ED medications cause significant vasodilation, relaxation of blood vessels, although they do it through different biochemical pathways. When you combine them, their vasodilating effects add up, or can even multiply, leading to a severe, precipitous, and potentially irreversible drop in blood pressure. This profound hypotension can cause fainting, shock, heart attack, stroke, and can be fatal.
That's an interaction everyone absolutely needs to be acutely aware of if they might be prescribed either type of medication.
Without question, it's a fundamental piece of patient education for anyone using nitrates. Doctors and pharmacists are usually very careful about screening for this.
Another important consideration mentioned with nitrates is tolerance. What's that about?
Yeah, this is an interesting phenomenon. If nitrates are present in the body continuously, day and night, the blood vessels can become less sensitive to their effects over time. They essentially stop working as well. This is called tolerance or tachyphylaxis.
So the body gets used to them.
Pretty much, yes. To prevent this loss of effectiveness, a nitrate-free interval is usually necessary when using long-acting nitrates for prevention. This means scheduling the doses, so there's a period of about 10 to 12 hours each day, typically overnight, when there's very little or no nitrate medication in the system. This daily break allows the body's sensitivity to the drug to reset, helping to maintain its efficacy long-term.
That's clever. Are there any other practical patient teaching tips from the sources regarding taking nitrates, especially that quick-acting nitroglycerin?
Yes, a couple of practical points. The sources advise avoiding eating, drinking, or smoking right around the time you take a sublingual dose, as this can potentially affect how well or how quickly the medication is absorbed from under the tongue. And importantly, they really emphasize proper storage for the nitroglycerin tablets. They need to be kept in their original airtight glass container, tightly sealed, and stored away from heat, light, and moisture. There are often images showing this specific brown glass bottle. Why? Because nitroglycerin is quite volatile and can lose its potency very quickly if exposed to air, light, or heat, or if transferred to a different container. Checking the expiration date is also crucial.
Good tips. And there was that specific caution mentioned in one of the sources, the Ninja Nerd video, about using nitrates in one particular type of heart attack.
Yes, that video specifically highlights that nitrates can cause a particularly significant and dangerous drop in blood pressure in patients who are experiencing a right ventricular myocardial infarction. That's a heart attack primarily affecting the right side of the heart. Because these patients are often very dependent on preload to maintain their cardiac output, the venodilation caused by nitrates can be catastrophic. So nitrates should generally be avoided in that specific clinical situation until the patient's hemodynamics are better understood.
Okay, so nitrates tackle angina mainly by reducing the heart's workload, lowering that preload by relaxing veins, but they also can help blood flow to the heart muscle itself. The sources also briefly touch on some other anti-anginal players besides nitrates.
They do, yeah. It confirms that managing angina often involves multiple approaches, not just nitrates. The Ninja Nerd video, for instance, notes that beta blockers drugs like metoprolol or atenolol are often considered first-line therapy for preventing stable angina episodes. They work primarily by slowing the heart rate and reducing the force of contraction, which directly decreases the heart's oxygen demand.
Right, hitting the demand side again.
Exactly. And calcium channel blockers are another major class mentioned. Some, like amlodipine or nifedipine, primarily work by dilating blood vessels, including coronary arteries, making them particularly useful if vasospasm is suspected. Others, like verapamil or diltiazem, also slow the heart rate somewhat, similar to beta blockers, affecting both supply and demand.
And ranolazine was presented as more of a last resort option.
Correct. Ranolazine is mentioned as an add-on therapy, or an option for refractory angina that's chest pain that persists despite treatment with other standard medications. It works via a unique mechanism involving sodium channels in heart muscle cells, which ultimately helps improve oxygen supply-demand balance. However, the sources note it has significant potential for drug interactions and carries a risk of prolonging the QT interval on an electrocardiogram, which can predispose to certain dangerous heart rhythms. So it's generally reserved for specific situations and requires careful monitoring.
Okay. Bringing it all together, then, it's really fascinating to see how these different classes of drugs, alpha blockers, primarily targeting those alpha receptors for things like blood pressure and PPH, and then nitrates, acting through nitric oxide pathways to relax smooth muscle, especially veins for angina, how they both ultimately influence the cardiovascular system and smooth muscle function, just through different mechanisms and with different primary goals.
Okay. That interconnectedness is definitely key. It shows that the body's systems aren't really isolated islands. Manipulating one part of the signaling network, whether it's the adrenergic receptors with alpha blockers or the nitric oxide pathways with nitrates, can have really widespread physiological effects. And understanding those links, those mechanisms, is absolutely vital, particularly when you consider how these different medications might interact with each other or with other drugs a person might be taking.
We've taken a serious deep dive today, haven't we? We've explored alpha blockers right from their basic lock and key mechanism and their, frankly, unbelievably diverse uses, including those surprising off-label ones like PTSD nightmares or helping pass kidney stones. And we dug into their critical side effects like that first dose effect or the serious warning about priapism. Then we shifted gears to nitrates, really understanding how they use vasodilation, particularly that venodilation effect, to ease the heart's burden in angina. We covered their specific uses, that crucial patient protocol for taking nitroglycerin during an attack, and of course, that absolutely non-negotiable warning about combining them with ED medications.
Yeah, and I think understanding the kind of precision required when we use therapies that interact with these fundamental signaling pathways really underscores both their incredible power to treat complex conditions, but also the critical importance of managing them carefully, respecting their potential side effects and interactions.
Absolutely. So here's something for you, our listener, to mull over as we wrap up. Think about how targeting just one single type of receptor, the alpha-adrenergic receptor, can have such specific impacts on something as systemic as blood pressure regulation, but also on smooth muscle relaxation in a very localized area like the prostate and bladder, and then potentially influence complex processes in the brain related to nightmares, and even relax the muscle in a tiny tube like the ureter. What does this incredible specificity, combined with such widespread potential effects stemming from the same receptor family, what does that tell us about the intricate, deeply integrated network that governs our physical body and maybe even touches on our emotional states? And what does it say about the delicate balance we strike when we use targeted therapies to intervene in that network?